Okay, wait, so I have to say hello now when you put me on? Okay, good. Hello, everybody. I'm very happy to have been invited to participate in this webinar. And I know and I understand that not much cryosurgery is done in India, but still I thought it was a great alternative to show to a group of surgeons, because I think cryosurgery offers the opportunity to have an extra tool for treating patients. I invite you to ask me any question if you have any questions for me. And again, my thanks to the organizing committee and the association for having me with you. I know many times the concern of people has to do with doing cryosurgery on skins type 3 and 4 and the possible hyperpigmentation. And I think I mentioned at the beginning of the talk that you need to be careful when you treat darker skin types, and to always try to do the cryosurgery on a less visible area to make sure that you get the right results. Yeah, in fact, that Dr. Dinesh Kumar is asking me about the skin color. I've worked for many years in Latin American country where skin types go from type 1 to very dark skin tones. And whenever I was asked to do cryosurgery on, for instance, small seborrheic keratosis or skin tags, or lentigos, I always told the patient to let me try a few lesions, like maybe on a side of the face, and see what the results were. Because with cryosurgery, you always generate inflammation, and with inflammation you can have hyperpigmentation. And if a patient comes to you for a benign lesion, what they're expecting is to look better, not to look worse. So before trying to treat many lesions and having a horrible result in a patient that will hate you for life, you better just go and try maybe just one lentigo on the dorsum of the hand or in a preauricular area, and have the patient come back in 3-4 weeks and see the results. If it doesn't look as you expect, well, you just tell them, this is not going to work for you. I mean, you have to be honest with the patient and offer something else. Sometimes you cannot offer anything because there are many other lasers can do also hyperpigmentation and other treatments and electrocoagulation too. So treating a lesion, a benign lesion with cryosurgery is just a way for you to see how that skin type is going to react. And I think that that covers pretty much the issue on skin color. Okay, I have a question here about keloids. The issue with keloids has been not easy to solve, because I don't think there is one treatment for keloids. And many times when you see publications, you will hear or read that they have excellent results on earlobes. Well, let me tell you, anyone can have good results on earlobes, and the difficult ones are the chest keloids. In this case, you don't really mind about if you get hypopigmentation, which is probably what you'll get if you freeze a keloid, because you need to freeze very deep, because it's a tissue that is fibrous and you need to destroy it. And there are several options of treatment for cryosurgery on keloids. One thing you can do is you can spray the keloid first, wait for it to thaw, and you're going to have a dilation of the tumor. There's going to be edema. Then it's going to be much easier to infiltrate with a steroid, the steroid that you usually use in infiltrations. As you know, keloids are hard many times and you're not able to infiltrate. So freezing first and immediately afterwards, you infiltrate. It works very nicely. For earlobe keloids, you can also shave put local anesthesia, just cut the keloid out, and then in the base that is left, you double freeze, thaw cycle, and then let it heal. And as it heals, just put some pressure on the region so that you don't get the keloid. And finally, the treatment that has been used lately mostly is the intralesional, where you get into the keloid with a special needle. Well, actually, what I use, because it's the cheapest one, I use the lumbar puncture needle. I go through it and out, because you're not injecting liquid nitrogen, you're going through the tumor and coming out. And then you do a freeze thaw cycle. It takes a long time. Actually, when it thaws, you just unplug your unit, because it can take half an hour for it to thaw, and it works. It can work very nicely. Dr. Zubolis from Germany has a great experience on treating keloids with intralesional technique. I have a question here. The duration of free thaw cycle? Well, it depends. When you study, the first time I studied cryosurgery, I got very nervous about this fast freezing and slow thawing, which is the principle by which you destroy cells. Well, it turns out you cannot really do too much about it, because what generates a fast freezing is the fact that you're using a cryogen that has such a low temperature that the difference in temperature between the skin and your cryogen is so large that the extraction, the removal of heat from that cell is very fast. Once that tumor is frozen, then it will take the time it takes to thaw, and it's usually very slow. You can measure it, freeze it with liquid nitrogen, and then take the seconds it has taken to freeze, and then let it thaw, and you're going to see it's going to be twice as much, or sometimes even more. Okay, here, any experience with cryo and prurigo nodularis? Yes, it can be very nice. It's sometimes these patients are desperate, they don't respond to anything, and you can freeze each individual lesions with a spray. It doesn't have to be a very deep freezing. Just spray it until you get the whole lesion white, and then let it thaw. They're going to have an inflammation immediately afterwards. You can have some topical steroids put on it, but then the lesion disappears much faster. Another question with respect to cost: we get pre-filled cryo cartridges, which work out expensive compared to conventional cans we buy from regular vendors. Also, I have seen the cartridges seem to get empty soon. Well, I don't know those cartridges, but the ones I know are not liquid nitrogen. They're nitrous oxide, which is not as cold as liquid nitrogen. And for instance, they work it's a cryogen that can work very nicely on benign lesions, but don't use it for treatments on skin cancer. You do need a cryogen that goes as low as liquid nitrogen. So just find out what those cartridges are. I mean, I think the cartridges are nitrous oxide. Another question, cryo and alopecia totalis. Oof, I would not do that. I mean, I've done cryo in alopecia areata in small areas, because basically what I do is I brush. It's like a brushing of the liquid nitrogen over the surface, just enough to get some inflammation, some irritation. And that seems to work and help. You can either just do that or spray lightly and then infiltrate, because then your injections will, the corticoids will penetrate better. But in the whole area, I've never read that of it doing it, and plus it must be very painful. So I don't see any other questions, and I invite you if you have any other questions on there is one thing that nobody asked, but I think it can be very helpful, and it's the cryosurgery used in hemangiomas. Before the time of propanolol, we did a lot of cryo on hemangiomas because it works beautifully. And what you have to use is a probe. You previously freeze the probe and you put the probe over the hemangioma and apply it with pressure just for a few seconds. And you would say, well, you know, I have a laser. Well, great. If you have a laser for vascular lesions, of course, you know, you have to use that and it's preferable. But I know that most people don't have lasers for vascular lesions. And if you have a small hemangioma or a lesion you want for it to stop growing, and you can use cryo. In cryo and freckles, yes, it works very nice. I've had, you know, but I've tried it in very, you know, light skin types, and it works fantastic. You can, and just freeze for, you know, seconds. Just go over them like if you were painting them with liquid nitrogen, because basically what you want is to the skin to you know, get stuck. I mean, it gets the next day you'll see the freckle look darker, and then in, you know, if it's in the face, in 3-4 days it just falls off. You will be left with an area that is pinkish, and in an extra week that or 2 weeks that redness, or actually that pink color, will go away. When do you opt for cryobiopsy instead of conventional? Well, I use cryobiopsy anytime I need to do shave biopsy. I see to me it makes no sense to put local anesthesia to do a shaving biopsy, because I have to inject, it's painful. I have to put the liquid inside the skin, it's painful. Instead, when you freeze and before, just as it starts thawing, you shave out it. You know, there is no pain involved. Then you put some hemostatic solution, and that's it. I've saved the hospital a lot of material, and I spare the patient a lot of pain. So of course, a cryobiopsy is a shave. It's a type of shave biopsy. If you have a pigmented lesion, for instance, you're never going to do a shave biopsy because you want it to remove completely. And so, you know, if you're suspecting a melanoma, for instance, well, you need to remove it completely, not by shaving biopsy. And I'm saying this because there are countries like in the United States where they do shave biopsies for nevis. Well, in Europe, we don't use shave biopsies when we have a pigmented lesion. Now, let me see. What is the endpoint of the frozen probe on hemangioma? The depth of the lesion. Actually, you're not really freezing too deep. You just freeze the probe. I mean, you attach the probe, freeze, and when the probe is frozen, you just go and get the probe on the skin with the hemangioma with certain pressure, of course not. You put pressure to remove or get the blood out. It takes seconds, and then the freezing that you do in advance is so that the probe does not get stuck to the skin. It really takes seconds, and then, you know, once the baby, because usually this is in babies, they will start crying. What I do, I usually have the baby come in with the mom with no food. So when I do the freezing and the baby starts crying, I have the mother feed the baby, and they calm down. It takes a few seconds, and then after a few days, it starts turning purplish, darker. No removal of crust has to be done because you can have the tissue bleeding, and just, you know, until it heals, and you can have part of sometimes all of the hemangioma, and sometimes just part of the hemangioma, but at least that part that is growing fast and that moms and dads are very afraid that it can bleed spontaneously. So even by just removing partially the hemangioma, the patients are going to be very happy. How effective is cryo slush in inflammatory acne? Well, what was used, the cryo slush was used a lot. I mean, you must have your age because cryo slush was used many, many years ago. It worked nicely because what you did with the cold, the patient felt very good because acne has an inflammatory component. And when you have a severe acne, you feel your face that is burning. So a cryo slush works nicely. It was done with not. It was done with a I don't know the name in English, which is that block of carbon dioxide ice, which you broke in pieces and you did the slush. You can do it. You can do the same faster with liquid nitrogen. You just spray it, and at the first thing that you'll see is that you see more inflammation, but then the inflammation will disappear faster. I still use cryo on acne for women because since you have no more options of treatments, I freeze each inflamed lesion. And if I want to drain, I drain afterwards. You cannot drain and then do cryo because you can insufflate liquid nitrogen in the lesion. So freeze first, very lightly. Then if you want to remove the pus, drain afterwards. The first 24 hours, the person is going to look worse, but then the lesion will disappear faster. Post-cryo depigmentation, well, depends on what you do. For instance, when I treat skin cancer and I do a double freeze thaw cycle, I will probably destroy melanocytes. And how do I manage? I just tell the patients that they're going to have an achromic or a hypochromic area. I have seen with years, because I have patients that have been treated with cryo and tumors, that after years it improves. It tends to improve. It's very, very rare to have a patient with an achromic area. They tend to improve. But I would think no. I know that even in darker skins with a double freeze thaw cycle, you tend to leave a hypopigmented scar. If you're doing skin cancer, well, you have to tell the patient, this is a risk and I'm removing this tumor knowing that it can, leave you a change in pigmentation. Depending on who you're treating, maybe if you're treating a very old patient and you're doing for palliation, well, you don't care about the pigmentation. But if you're treating a younger person with a skin cancer in the face, well, it does matter. And then probably you will want to choose another technique and not cryosurgery. Do you use the dipstick, that method, and in which conditions? Well, I never use the dipstick method. I don't like it. And the reason why I don't like it is because you have no control of cold. You basically take this cotton buds, put it in liquid nitrogen. The liquid nitrogen gets inside that cotton. I have seen sometimes the liquid nitrogen suddenly come out of the cotton bud and burn the patient. Plus, you have no control on temperature. You don't know. I mean, by the time you take and dip the cotton bud and go to the patient, the temperature has gone up a lot. So no, I never use it. I just prefer to spray because I want to feel control on what I'm doing and the temperature. In children with multiple molluscums, oral mucosal cryo is very rewarding. Using gauze impregnated with acetone or even wet gauze works well to prevent the probe from getting stuck. Okay. In children with multiple molluscum, the first thing I do is that I hydrate the skin because molluscums usually appear in very dry skin. So put a lot of hydrating cream and have the child come back in 2-3 weeks. If you have decided to do something about them, then have the child come back with a topical anesthesia of any kind that you have available. And if you decide to do curettage or cryo, if you're going to do cryo, just get one of those cones that are used for the ear examination and just freeze exactly where the molluscum is. Oral mucosal, in fact, was very nicely. You just put a probe, freeze. You can freeze the probe in advance and then get this frozen probe stuck to the mucosal. Dry the mucosal as much as you can, because with the wet mucosa, you can get the probe stuck, and then you have an extra freezing that you don't want. If your probe gets stuck, then one trick that you can have is to have a glass of warm water next to you. And you can always let some warm water. You put a lot, you have to put some water, because if you put just drop by drop, then you're going to have a nice block. Just very fast get some warm water so that you can unstuck the probe. This is I'm saying this because once you have a probe stuck to a mucosa, do not ever pretend to unstuck it by doing pressure, because you're going to break the tissue and it's going to be a disaster. You have to be very patient. You need to let it thaw and then remove. Gauze with acetone, actually, gauze with water, like you were saying. I mean, just water is enough. Water, or but now it's the contrary. If you want the probe to get stuck, which you do sometimes, for instance, in skin cancer, you can put ultrasound gel and then put the probe, because you want the probe to get stuck, because you're going to freeze very deep. When you don't want the probe to get stuck, just get it very dry and freeze it first. That's the trick you can use. Size of the lumbar puncture needs for intralesional, well, it depends on how large your keloid is. I usually use the standard, needle, because when I've done it, I've done mostly more than keloids. I've done it in very large malignant tumors. I just get the lumbar puncture and I go through, actually before I put it in, and while it is still inside the sterile bag, I bend it slightly, so it's easier for it to go in and go out. How do you protect the eyes when you do cryo? Well, one thing I do for sure is never use metal. I've seen people that come out with metal coverage for the eyes. No, because metal is an excellent conductant of cold. You can use some plastic, previously sterile plastic tongue depressors that can work nicely. And if you're working on eyelids, just move the eyelid away from the eyeball, and that's enough. Cryo rollers, do you use often? I don't know what the cryo roller is actually, and for what indication. So Jack G, if you can write what a cryo roller is, I will appreciate, so that I can answer. Which method do you use for the eyelids? Well, I've done many treatments for eyelids. One is probe. So if I have a skin cancer in this area, I just move down a little bit and I just get my probe on it. That's it. My colleague from Finland, Dr. Suhoni, and also the group from Sweden, Hello. They have a lot of basal cells in this area. Basically, they move away the eyelid and they use rubber cones. And with those rubber cones, they freeze inside the rubber cone. So they only freeze the area they're meant to freeze. Cryo for keloids, I think I spoke about it. You can either freeze and then inject, or you can do intralesional cryosurgery. Recurrent myxoid cyst, well, it does happen, because the myxoid cyst sometimes, it's the structure of the cyst is pretty deep, and you can get recurrences. When it works fine, it's fantastic, but when you get recurrences, I have tried twice, and when I see that the third time they recur, I just leave them, or just send it to a surgeon, and then they will have to have it removed by surgery. Will you give intralesional steroids along with or after the cryo? Well, as I was saying, with the keloids, I spray. You can spray first, and let the edema help you inject the solution, because what happens with many steroids is that they're very hard and you cannot get the injection through. But it's right after, immediately. I mean, you freeze and inject. When you do intralesional treatment, you don't need to inject anything. You just, you do the intralesional and let it, go through the process of healing. Cryo alone, or for, yes, for just keloids. Those, as I was saying, are the hardest ones. How many freeze-thaw cycle would you give in genital ward? Oh my God, just one. I mean, the genital area is a very delicate area because the skin is very, very thin. Don't ever overdo it. I mean, you don't want an ulcer in that area. Again, for the warts, what I do is that I previously treat the area with an immunomodulator, because when I do that, some of the lesions will just disappear. Others will get smaller, and I have improved the whole area, immunologically speaking. Then I have the patient, I tell the patient to do this for 3-4 weeks and then come to me with topical anesthesia. And I freeze whatever is left. Just one freeze thaw cycle. You don't have to, it takes seconds to do each lesion. In the penis, in men, don't ever, I mean, if you have many condylomas around the penis, just do one side first. Because if you do the whole area at once, you might end up with a pseudophimosis. So you do, and I'm speaking about the longitudinal axis. I mean, just do one half first, let it heal, and then the other half. Because depending on the skin type, you can have more edema or not, and you want to avoid the pseudophimosis. Okay, the rollers are handheld removing drums at the end of the handle to be dipped in cryo and rolled over the nodular cystic. Okay. Okay, well, I've never used that. What I used at some time in my life, it was a probe that looked like a doorknob, because it was a doorknob. We had, with the Brimel Corporation, they would take the doorknob and they would Teflon it. And then it was a probe. On the other side, it was just a regular probe. We just put that on the unit. We use that to do basically what you're saying there. We would iron the face. And we used it as a peeling for hypertrophic vascular malformations. It was done a long time ago. I still have my doorknob somewhere, my Teflon doorknob, and I would not use maybe that doorknob on acne, because with acne you also have a lot of pus, and I would not like to be just going around with the roller or with the probe around the face. I think you might want to try that just the spraying. Brimel, and I have no conflict of interest with Brimel. They have one of the endings of the unit. It's called the acne tip. It's not round. It's long, straight, and what comes out is basically, you are able to just paint over, because you get a lot of liquid nitrogen out in a longitudinal fashion. Genital area, how many seconds? 1-2 seconds. It really is, going on each one a few seconds. I mean, I prefer to have some warts left than having a patient with an ulcer. And usually it's enough. I send the patient home with the topical imiquimod the same day, just like it's done with cryoimmunology, that you put imiquimod, spray, send the patient home with imiquimod, then have the patient come back. And that combination works better than just imiquimod or just cryo when you combine both. Antibiotic coverage required after cryo? No, actually, you don't need antibiotic coverage. The natural history on a cryosurgery, let's say you do a basal cell carcinoma. what will happen is that you have a lot of inflammation and you have the movement of liquid out. I had a professor, my professor in cryosurgery, he was a very funny man. He would say, even if you put the bacteria on top, it will never get infected because the liquid is coming out. And the deeper the cryosurgery, the more liquid will come out. And what you need is to have the patient change gauzes very frequently. Once it stops draining liquid, which will happen in a week, 2 weeks, depending on what you have done, well, then that's where you have to be careful about infection. And if you feel, because you know your patient, if you think your patient is not going to take care of the area properly by cleaning it, then you might want to have a topical ointment of antibiotic to protect the patient from an infection. But that question was, and then painkillers. Some people are more sensitive to cold than others. I've done warts, and I have the patient call me back and say, I have a horrible pain, or the next day they have pain. Yes, you can have some painkiller. By the way, if you have done a cryosurgery and the patient was doing fine, and after 1 week they call you and say it's painful, the probable thing is that it's infected. So the patient was doing great, and after 2 weeks they get pain, because you do not have to get pain afterwards. And if you get the pain afterwards, it's because something else is happening, and then you might not want to use either covering with antibiotic ointment or even give them oral antibiotic. It happens sometimes. Some patients don't clean the area very well. Remember that with cryosurgery you get secondary healing, and so it's the same process. It takes time, and people have to take care of the area. Have you used CryoPen? Yes, I have. It's a very nice equipment. It works very nicely for benign lesions. It's very easy to control. You need the cartridges, yes, and if you have availability of that, well, it works very nicely. For me, that I do a lot of skin cancer, it's not so useful, but I think that it's nice to have it if you will mostly do benign lesions, and even if you have somebody do them for you. So now in the States, they have the physician assistants that can do most of the tiny things, like a lentigo or a solar lentigo or a wart are done many times by PAs, and CryoPen can work very nice. Post-operative phimosis, well, it's actually a pseudo phimosis. Is a real concern. Yes, after treating, yes, it can be. So you just need to be careful on which ones you treat, and never go around the whole penis, so that to avoid that. Ideally, what gap should be there between 2 sittings of cryo? Well, it depends on what you're doing. I mean, if I'm doing multiple subkeratosis and I'm doing, some today and then some another day, you can do them in a week, whenever you want. If you're treating skin cancer and you have the lesion healed in 3 weeks, you need to check on that patient 3-4 months later at least, because any process that destroys tissue and then has a regeneration afterwards will need time for you to see the end result. I mean, so don't expect to see the end result in a week or 2 or a month. You need to leave more time. So it depends on what you're doing. What would be the approximate downtime with cryo for inflammatory acne? Seconds, just seconds, because basically what you're generating is a inflammation, an extra inflammation that will help then resolve the lesion faster. How can we avoid hypopigmentation in molluscum? Well, after cryospray, if you get hypopigmentation in molluscum, is that you are freezing too much. I mean, my concern in any case will be to get hyperpigmentation, especially in skin types 3 and 4. So If you ask me, I only do cryo-molluscums in the adult, because if I have an adult with molluscums, it's usually a large lesion that if I curette, I'm going to have a lot of blood. And if I have molluscums in an adult, I also might be in front of a patient that might have another venereal condition, So I prefer to do spraying and reduce the risk of contacting blood. But for children, I don't use cryo mostly on children. I just use a lot of hydrating cream and have the child come back, and then curette lesions after 1 hour of topical anesthesia. Oh, hello is saying Anand, but but there is no question. Then maximum area that would be comfortable treating in one session, like in multiple subkeratosis. I just let the patient tell me. I have patients that love to have the subkeratosis taken out, and they come, very regularly, and they sit there, and it depends on the day. Some days they tolerate more, and sometimes they just say, "Okay, stop, Dr. Pasquali, go away, and I'll come back another day." It depends on the patient. Some patients tolerate and have a lot, many. Some just say, two, just do two today, and I prefer to come back. There is not a maximum. You can do as much as you want, because it's really, it has no other secondary effect than the ones that you get on the area. So feel comfortable and know that you're not doing anything that the patient cannot tolerate. It's just a matter of tolerance of pain. Well, I think thank you, Doug, and thank you, madam. No, thanks to you for all the questions. You have had that many things. Can mucosal be treated with cryospray? Yes, you can, but I prefer mucosals to be treated with a probe. I have many probes. It's patients, but not patients, sorry. Students many times ask me, oh, how many probes do I have to have? Well, I said it's like, when you work in the kitchen and somebody asks you, how many knives do you have? And I said, well, I have many knives because I like to cook. And since I like to cook, I have many knives, one for each thing. Cryosurgery is a little bit the same. I mean, if you want to do cryosurgery, you will end up buying, many probes, because you want to adjust. You want to have one for each lesion. You have to have the tiny ones if you want to use it in sebaceous hyperplasia, but you want to have very large ones when you do large tumors. So for each one, you will need one. Well, I think we're done with the questions, and I want to thank you again. The only part that I don't like about this is that I don't see you, but just the questions, make me feel very nice, and I know you're there. Thank you very much again to the organizers, and I hope you get. Yeah. Thank you very much again. Thank you.